Good afternoon, everybody. This is Nancy Del Mastro with Adirondack Health Institute, and I want to welcome everyone to our November Telehealth Learning Collaborative hosted by the North Country Telehealth Partnership, a joint effort between Adirondack Health Institute and Fort Drum Regional Health Planning Organization. To start, as always, we'll be hearing from our state representatives on telehealth policy and regulation. We'll turn it over to hear from any CMS updates on the Medicare end, and then we will turn it over to our featured presentation for this afternoon. So with that, I want to turn it over to Kate Bliss with the New York State Department of Health to provide any Medicaid updates.
Hi, good afternoon. For the last, I guess we have some telehealth policy changes coming, and I don't know if everyone is aware that the Department of Health published regulations in September related to telehealth permanent policy. So over the course of the public health emergency, we've had emergency regulations that allowed for things like audio-only telehealth. But in September, we filed permanent regulations that will allow us to continue using audio-only telehealth after the public health emergency ends. And in that regulation, we also established e-consults, virtual check-in, and virtual patient education as modalities. And we also expanded the list of provider types that can appropriately bill for telehealth within Medicaid. We are currently working on a comprehensive guidance document, which will be released as a special edition Medicaid update. And in that comprehensive guidance, we will outline policy for those new modalities that were established in regulation. And we will also list out new billing guidelines. So there are billing modifiers and place of service changes that we're going to be putting in place. And that'll all be outlined in that comprehensive Medicaid update. We'll also try to pull together some of the frequently asked questions that we get and put answers to those in that Medicaid update as well. I also wanted to mention that over the summer, we completed a telehealth consumer survey that we made available through social media, and also we worked with provider partners that would post QR codes in their offices or reach out electronically to their patients. We had about 7,000 responses from all over New York, people telling us about their experiences with telehealth. And we also really wanted to hear from people that had not used telehealth. So we collected responses from them as well, asking about barriers to using telehealth, or for people who did use it, we asked what they liked. We also asked about insurance coverage so we can parse out the results for those that are enrolled in Medicaid, compare them to those who are not. So we're in the process now of analyzing that consumer survey and are very hopeful that the results of the survey and the information collected in the survey will help us better understand what focus areas need more attention within telehealth policy, and we'll be able to better plan for how telehealth can be better used in the future.
Thank you so much, Kate. That sounds awesome. And I'll be sure to share with everyone the regs from September that Kate had mentioned, as well as those survey results when they are available. With that, I'll turn it over to Kelly Grace from OASAS. We do not have any OMH updates to share right now, but if there are any, I will, of course, send those out in an email.
Hey guys, this is Kelly Grace from OASAS Counsel's Office. We actually don't really have any updates either. We did extend our commissioner's waiver that basically covered the extension of anything that we didn't make permanent via our regulations, but those were finalized back in the spring. But throughout the national public health emergency, we just continuously extend our own commissioner's waiver to ensure that there's no gap in coverage there. But that's it.
Thank you so much, Kelly.
Welcome.
With that, I'll turn it over to Tony from CMS for any Medicare-related updates.
Hi, yeah, good afternoon. And there's a section on telehealth in the final rule for the Medicare physician fee schedule that was actually published in the final form in the Federal Register on Friday. But basically, that there's three legal provisions that affect the Medicare telehealth coverage and payment policy. The original law, with the exception of opioid treatment programs and nephrologists providing monthly ESRD management services. With those two exceptions, the site of service for Medicare telehealth has to be in a rural area and in a healthcare facility where the patient is in a healthcare facility as the originating site. And that was changed, well, under the waivers for the public health emergency. Basically, we started waiving the requirement that it be in a rural area and waiving the requirement to allow payment for telehealth services to patients in their homes. And there was a Consolidated Appropriations Act of 2021 that came out in December 2020. And basically that made coverage of telehealth outside of a rural area to patients in their home permanent for services related to the diagnosis, treatment, or evaluation of a mental health condition. And then there's a Consolidated Appropriations Act of 2022, which came out in March of this year, which basically says that once the telehealth, the public health emergency ends, the existing rules regarding Medicare payment for telehealth are extended for 151 days. So put all of that together, and basically that says that until the 152nd day after the end of the public health emergency, the way things work now will continue to work as far as Medicare coverage of telehealth goes. Once the public health emergency ends, and those 151 days go by, the certain services that are paid, on a telehealth basis right now, wouldn't be no longer be covered. And I'll refer you to page 59 of the. I wonder if I can share. No, I'll refer you to page 59 of the final rule. And basically what it comes down to is eye examination, radiation therapy treatment management, eye exams, ventilation management, initial observation care, initial hospital care, domiciliary care, home visits, phone work, the 99411, 99443 services. All of these will no longer be covered by Medicare. But I'll refer you to page 55, which lists a number of services where there will be covered until the end of 2023, or the end of the year, calendar year in which the PHE ends. Okay, and these are services. Let's see. Psychophysiological therapy, biofeedback training, eye exams, tympanometry, various audiometry services, uh, tinnitus evaluations. Yeah, there's a number of services where they're keeping them on the telehealth list, because they feel that they may be able to justify adding them permanently. Okay. The criteria for permanently being on the telehealth list is that it's a service like a visit, a visit or a consultation that is in the original law, or certain services where there's a clinical advantage to doing them by telehealth, and basically they're going to be keeping these number of services valid for telehealth service payment until the end of the fiscal year and the calendar year in which the pandemic ends, to allow people to develop evidence for adding them to the permanent list. The 151 days, let's talk a little bit about that. It means like for non-mental health services, if it's on a service that's listed as covered under telehealth, it can be done with the patient in their home, and the billing would be using modifier 95, and the place of service code that would ordinarily be the place of service where the patient would be seen. Once the 151 days goes by, okay, we get back to the original law, 1834M, if there's no, legislative fix, and if the patient is in a facility in a rural area, the telehealth would be billed using the place of service 002, and if the person is in their home and it was like a mental health telehealth service, that would be covered, or a opioid treatment program service, or a nephrologist providing patient management for an ESRD patient. The service would be reported using modify a place of service 10. Okay, and the one change is that it would be priced using facility level allowances under the Medicare physician fee schedule. And the other change is modifier 93 as a indicating audio only telehealth. This modifier will be accepted starting January 1st, 2023. There's also a little section on telehealth for mental health services in the outpatient prospective system, a final rule for calendar year 2023. And basically it makes the current, waiver permanent for services that a hospital outpatient department provides to a patient in their home. The one proviso is that, once the pandemic, the public health emergency is over, the same rules that applied from the Consolidated Appropriations Act of 2021 apply. In other words, for a telehealth service to be billed, there must have been an inpatient rather an in-person service provided to that patient within the previous 6 months. And for the telehealth services to continue, there must be an in-person service provided within 1 year, with certain exceptions. So, and the other thing, proviso for the hospital billing for a patient in their home is that there's no professional fee billed for the same service.
Thank
So,
you so much, Tony. I do not want to cut you off because this is all so valuable, but I do want to
okay,
be mindful of the time and give our
okay,
presenters some time. But
yeah,
if you have any other updates, please send them in an email, and I'll be sure that all of our
no,
participants
yeah, I
have
should,
them.
that was all I had. That was all
Thank
I
you
had,
so
Nancy.
much.
So, okay, yeah, be well.
Great. Thanks, Tony. Yeah, no, as mentioned, I'll make sure for our participants, everything mentioned by Tony, as well as Kelly and Kate, are noted in the notes that I'll be sending out later this week. And of course, this is being recorded, and I'll send out that link as well if you want to reference back to anything that was mentioned. I did put in the chat the updated reimbursement information from Kate for DOH telehealth. So please feel free to check that out at your convenience or leisure. And with that, I'm going to turn it over to our two presenters for today, Mike Maffey and Peter Kaplan, to talk about healthcare staffing challenges post-COVID.
Nancy, thank you. Can you hear me?
Yes, I can.
Okay, great. I'm Peter Kaplan. My company is eHealth Systems and Solutions. In my many years of doing telehealth consulting, mostly in the strategic planning side of it, I've worked with a lot of different vendors to sort of model the best solution for our clients. And in doing so, as many of you are realizing, the pandemic has definitely taken a toll on our clinical, both on-site and virtual care provider networks. And so I came across recently AlediumHR, and I'll let Mike introduce himself, but they have a unique outlook and approach to staffing, which in the scheme of things, whether you're looking to build your bedside or website staff, we ultimately will need people at both ends of these calls. So I would like to suggest that part of what we're trying to do is help build the solutions that each of your organizations need to develop in order to be an attractive and to retain staff. And then there are some new models that we are starting to explore to help you manage and master the ability to recruit and onboard and then retain people in a very tight market, especially one where we know that students coming up through the nursing schools and the medical schools are not at full capacity. So we are going to be facing one of those challenges where we have an aging population with many special needs groups, chronic conditions that need managing and monitoring. And we are going to be faced with trying to find the right mix of personnel and staff that will support all of those use cases and clinical needs. So having said that, I will let Mike Maffey introduce himself and tell you a little bit about Aledium and how we approach the staffing and recruiting challenges that you'll be facing over the next 3 to 10 years, actually. So, Mike?
Thank you, Peter. I appreciate it. Nancy, can you hear me okay?
I can. Thank you.
Okay, thank you. As Peter said, I am founding partner and president of AlediumHR. We were founded in 2013, and our traditional healthcare model was focused on telehealth. And this was pre-COVID. So as you can imagine, though telehealth has been around for several decades, it's nowhere near where it is now when we started in 2013. We started in 2013 in telehealth primarily because several of our partner hospitals were looking to explore options in the space. And they asked if we could or if we would partner with them on the recruiting and staffing side. When COVID hit, and we can remember the date pretty well, it was March 6th, 2020, when then President Trump mentioned the word telehealth. And since that time, which is, believe it or not, almost 3 years ago, our business has increased tenfold into areas that we would have never imagined when we started in 2013. So as a company, just very briefly, we specialize naturally in telehealth, but we also do health tech, healthcare support, biomedical, and all traditional bedside clinical and non-clinical roles. And we work with hospitals, home care providers, clinics, technology companies. And with the advent and growth of telehealth, there have been a lot of startup companies, remote patient monitoring companies that have started up over the last several years that we have also been supporting. Came across this cartoon a couple of years ago, and those of us like myself who are old enough to remember the Jetsons, this was all the way back 60 years ago. And when you look at the pictures, you see telehealth in practice right there. And I thought when I uncovered this cartoon, I thought it was pretty interesting, something 60 years ago, showing really in a lot of ways how telehealth, outside of the comedy of it, how telehealth is practiced today. So I just wanted to start off there with a little levity that in the cartoon industry, or the Jetsons understood telehealth 60 years ago, but even before we did. Some of the key learnings over the next 25, 30 minutes that we hope that you get out of this is identifying the right balance between telehealth and traditional healthcare. And what I mean by that is with telehealth, there has to be a balance, or there is a dichotomy, taking place in the industry, where you have, the needs from a provider and hospital bedside standpoint, but you also have these needs that have been generated through telehealth. And so jobs and positions that may have not existed, as I said earlier, 3 years ago, are suddenly being, performed and are seen as a competitor of the traditional healthcare staffing model. So a lot of us in the industry are appreciating, certainly the challenge of hiring, recruiting, building a successful recruiting strategy. The cost of that has gone up tremendously. I'm sure all of you over the last several years, especially those who have used travel nursing, have seen an exorbitant amount of money spent on travel nursing due to shortages, also due to illnesses, and just purely, naturally to COVID in general. But we have seen as a company, healthcare budgets, recruiting budgets, double in size, triple in size, to where they're having to spend money just to operate on the day-to-day. And as Peter mentioned, when you're looking forward 3, 5, 10 years, this industry is going to continue to change. The resources, the lack of resources, what's telehealth going to look like over the next several years? Anthony went over a few things earlier about the Medicare laws as they attribute, or Medicare billing as it's attributed to telehealth. Is there going to be any action by Congress to make these laws permanent? So there's a lot of unknowns, but what is not unknown is that we're going to continue to have a staffing challenge. So at the introduction, we're going to talk about what has changed pre-COVID, post-COVID, what does the outlook look like? What can you do? Several suggestions, and then we'll end with any questions that you might have. In the chat box, Nancy will be monitoring any of the questions. Those that we're able to get to, we'll answer during this webinar. Those that we don't, we'll make sure to get those from Nancy and provide the answers to them. By no means are we going to be able to provide everything that we know about the industry. We have a very broad view, having worked with hospitals and healthcare organizations across the country. We have a very broad view of what is happening right now. And what is happening in the Northeast is different than what is happening in Southern California or on the Gulf Coast of Florida. But what is all relative is that everyone is having difficulties finding staff, whether that be nurses, physicians, clinical, non-clinical roles, you name it. Everybody is having difficulty in that area, regardless of the region of the country that they're in. But what can we expect from the healthcare job market, moving forward? What are some of the things that AlediumHR has seen and observed? And also, what is the industry? There's a lot of industry stats and numbers that have been presented over the last year or two that give a pretty realistic picture of what we can expect over the next several years. And of all industries, and I'm not speaking to anyone who is on this webinar that does not understand this, is that healthcare has been impacted most by the pandemic. And so what is going to happen to healthcare in general moving forward? And then what is the challenges that we're seeing overall in the industry? And then what is that path that you can take? We'll present several insights, suggestions on current trends, what we're doing as a company to help our clients and our partners not only staff more expediently, but also from a lower cost standpoint. So what has changed? Well, post-COVID, and we as a company can attest to this. Telehealth was growing about 19-20% per year. We were doing telehealth roles and positions. Most of them were surrounding remote patient monitoring. But it was level growth. We were seeing year-over-year growth since we started in 2013 naturally, but nothing like we have seen in the industry over the last 3 years. And the 3 top positions, specialty services or positions that have been the biggest ones that we are seeing from our clients from a recruiting standpoint or from an ask standpoint revolve around nurses, therapists, and physicians. And I would say the biggest for us has been on the nursing side, on the RN and on the NP side, specialty side, ER, cardiac, etc. That has been by far our fastest growth area for us in recruiting and need. But probably the one that has grown the fastest has been the therapist side. And so you have seen this, I'm sure, with several companies that have started up over the last several years, other remote therapist companies like BetterHelp, etc., that are hiring thousands of therapists. And it has created a huge burden on the market because of the pure numbers that are needed. About a year ago, I spoke with the CEO of BetterHelp, and he was saying they were signing up 10,000 patients per month. Now, this was probably in the middle of COVID, and maybe that number has come down quite a bit. But if they have 10,000 patients a month signing up, you have to have the numbers of therapists in order to work with those patients. And it just was not happening as fast as the subscriber base was growing. So when I say the pandemic has changed everything, I wanted to give that kind of background, because what we are seeing now is I would not call it a mass exodus of staffing from the healthcare industry or medical workers, but it is a much faster rate. And because of the pandemic, the reasonings for leaving the position within healthcare, whether it's nursing or any type of clinical or non-clinical role, the pandemic had the biggest effect on that. The frontline workers, long hours. Not going to go into a long dissertation about the pandemic because we all understand the impact that it had on healthcare, but it really had an impact on the movement of these medical workers, not only leaving the industry in some aspects, but also leaving for other jobs. And as you can see, there's two factors here that played and we talked to nurses, we talk to physicians, therapists, lab workers, technologists on a daily basis. And the real change that we're seeing happen is the competitive nature and the number of jobs that have been created by telehealth. So from an option standpoint, using a nurse that may have worked 30 years in a hospital, several hospitals bedside, and has worked three 12-hour shifts, worked holidays, etc. Now, as an opportunity comes available for a remote RN, pays close to the hourly wage that they were possibly making at the hospital, not as much, but pretty close. And now a lot of these positions have Monday through Friday, normal business hours, and they don't have to work holidays and weekends. That's the biggest change that we have seen, is the pure number of positions, the growth of those types of positions over the last several years. So unlike pre-COVID, there's more options available. So you see the second statement there, wanted more money or better benefits. Is certainly, we're hearing that a lot with the options that are out there. And then the other side of this that we hear in our discussions when we're interviewing is the mental health crisis. And this is nothing new either, but it has really gotten worse during COVID and post-COVID. And a lot of the reasons why individuals are looking for less stressful positions. Telehealth happens to provide that versus what they may have been doing in their previous job. Same skill sets, but they're using that experience, that background, that skill set in a much different way. And so the competitive nature of this is when you create these types of jobs with less stress, less hours, and the pay pretty comparable. You are going to see, and we have seen, the increase in the number of healthcare professionals leaving the traditional roles that they had for telehealth. This is just a brief slide on, as I mentioned at the beginning of the conversation, we have the benefit of seeing the U.S. as a whole when we're recruiting, and understanding where the shortages are, why are the shortages taking place in certain states or certain regions of the country. So this is a chart from March of the states and the shortages that are taking place. And I'm not going to go state by state, but it's pretty easy to understand there's not a state that is not going to have or is having an issue as it pertains to nurses. It's going to be, of all of the positions in healthcare, and I wrap healthcare and telehealth together, it is going to be the most competitive moving forward, because not only now do you have more options, but you have the retirement of nurses leaving the profession. You have less graduates coming out of the nursing schools. And then the baby boomer population is increasing in age. So it's a three-pronged effect, so to speak. So you have hospitals, you have nursing homes, home health. All of these areas and more need nurses. So the shortage is not going to get any better. And based on what we're seeing internally as a company, it's going to get worse. And so the effects of staffing shortage are very varied, but they really come back to this one area. And this is a favorite slide of mine, because it shows that a lot of the reasons that a healthcare worker is leaving or is impacted is because of the staffing shortages where they work. And you're seeing hospitals that are closing down ERs or pediatric wings simply because there's just not enough staff to staff these areas. And then those that are understaffed are constantly hiring to keep up with those who are leaving and to keep up with the growth. Hospitals are still being built. There's still patients coming in. And so people in these types of jobs, they are affected greatly by this. And we can validate this information, again, going back to having these personal conversations with healthcare professionals across the country. And we keep track of this internally when we ask the question, why are you leaving? Why are you looking for a new position? What is it that appeals to you about telehealth if they're looking at a telehealth position? And it really revolves around, the stress of the job and the stress being caused because in most cases, the shortages of staff. So in theory, you can say COVID is past us, but it has changed the way we look at recruiting and staffing forever, simply because of the way it has changed the industry, from both a worker standpoint and from the types of positions that we're going to see in the future. So it's not the standard way of looking at how you recruit anymore. You can't just place a job posting and expect, in a lot of ways, to get a lot of candidates. You can't just hire a recruiter, give them a job, and say, fill the position, and they try to do it the same way that they've always done it. It just doesn't work anymore. And this is the cost side, which I mentioned earlier about the travel nursing piece. And we've never done travel nursing, but the rise of using a temporary workforce a contingent workforce to help supplement staffing is going to continue to rise. I think travel nursing is going to be undergoing a change because of the cost structure being got so out of hand during COVID with the high costs. But it's not going to have an effect on companies who provide contingent staffing or temporary staffing, temporary nurses, your locum tenens with physicians, filling in shortages on certain schedules in the hospital, because you just don't have the numbers that you can recruit on your own. And this demand is going to continue to get greater because of clinician shortages. So the rise in having a partner, several partners, to help supplement that staffing, the costs are going to continue to rise along with the pure numbers that you may need. But what can you do when you look out into the future for staffing your facility? It's not just bringing in the numbers that you need. It's also looking at ways to help relieve the strain on your workers that are there. And looking at, healthcare in general, the way healthcare is dispensed, the way the patient seeks healthcare, is going to be as equally and maybe even more important, because it's going to have a net effect on how you look at the future of how you run your organization. And so in this chart here, with the rise in the baby boomer population, the aging of the baby boomer population, hospitals are looking at ways to how to shift a percentage of their beds to the patient home. How can that be done? Through various methods that even some of you are probably, looking at to relieve some of the strain. Virtual. This is something that is not going to go away. There's going to be continued pressure on Congress to make this a permanent part of healthcare. There's a lot of things going on in the industry that are the fallouts. There's been fraud. There's been Medicare, Medicaid fraud uncovered in telehealth. There has been issues with prescription or the prescribing of medications through telehealth. None of this is surprising because it's just another form of healthcare delivery. But these things are going to have to be worked through, and telehealth is not going to go away simply because the public will not allow it to go away. There are too many things now that can be done virtually for in-person instead of in-person care. I think most of us have maybe even utilized some form of telehealth, but in theory, the individuals that are using it, that like it, that don't have to go into a hospital or into a physician's office, are going to continue to want to use it. And naturally, the last part is, you see these retail clinics, these individual emergency rooms. I live in Tampa, Florida, so we're seeing a lot of growth down here in this type of healthcare, where patients are willing to go, to a CVS or a Walgreens or an HCA standalone clinic, Blue Cross Blue Shield. I'm part of that. They've got their own wellness clinic now to where you can go to and get x-rays and get almost anything done that you could get done at a doctor's office or at an emergency room, and you do not have to pay for the first 2 visits. So these are things that leaders in the healthcare industry are looking at, because they need to be looked at to relieve some of the strain that is happening internally within their hospital organization, our healthcare organization. No, we're getting short on time, but I really wanted to go through this, and I'll go through it quickly, and we'll certainly, as I said at the beginning, be available for questions either after this or even through a video or phone call at whatever is convenient for you. But according to research, a new RN resigns from their first nursing job within the first year and their third within 2 years. And we can validate that internally because we are seeing a lot of resumes, and we're using nurses as an example right now because it is the most impactful, but we could say similar things about therapists. We could say similar things in some aspects about physicians, but the nursing side of this, post-COVID or pre-COVID, excuse me, we would get resumes in from nurses, 3 or 4 years on the job. Now, there's no hesitancy if they do not like the position of them looking for another role within, 6 months. It just depends on the situation. That's why you see all of these hiring bonuses. There's one healthcare chain that's offering $30,000 hiring bonus for new nurses. They have gone in and I'm sure looked at the ROI of attrition and said to themselves, or based on the numbers, look, I can afford to pay the $30,000 hiring bonus. Naturally, the nurse has to stay a certain length of time, but I also compared it to what my attrition is, what my lost revenue is. And so when we work with our partner companies, partner hospitals, etc., not only are we talking to them about the recruiting end, but also what are you doing to improve and focus on your staff retention? And I think that is probably more important in some aspects than recruiting. A recruiter, when you give them a position, whether it's an internal recruiter or external recruiter that you're working with, they're just focused on getting that person in the door and hired. Well, I think also the focus has to be on why are they leaving? And we always focus in this industry on patient, how the patient satisfaction was when they were in the hospital. How was their stay? How were they treated? We always get those surveys, but do we really look at the employee satisfaction? Why are they leaving? Why are they staying? What are we doing to help retain our own employees? So as a company, AlediumHR as a company, we are just as focused on partnering with our partner companies, on this side in sharing what we know in best practices as we are on the hiring side. And a lot of we work with is the brand. It's very hard. I was talking to a very large hospital organization here in the U.S. Although they have facilities all over the country. And we were talking about the number of openings that they have at any one time, and they have about 4,000 openings nationwide at any one time, all shifts, all hospitals. So what is it about that 4,000? Why do you need so many? What is your brand? What is your brand in the marketplace? What is your reputation? Are people leaving because of it being a place to where there's no enjoyment doing their job, maybe not enjoying it because of the hours, etc. But this gets out into the market, and we, again, when we're talking to these healthcare professionals, they're giving us the answers as to why, they're wanting to leave their current position. So the more that this gets out gets out into the market, the harder it can be for you to attract people. And it is far more difficult. And I know I'm speaking to a group now that truly understands this. And this could be an entirely separate presentation, but it is far more difficult in a rural environment than it is in a major metropolitan area. But don't forget the major metropolitan areas have hundreds of more openings than probably the rural hospitals, but they certainly have a bigger population to pull from. So when we're partnering with organizations in a rural area, we have to, meaning AlediumHR as a company, we have to focus on these two things. We have to work with our clients on staff retention, and we also have to focus on attracting those individuals because it's a brand someone wants to work for. That's why in our business, and meaning within AlediumHR, we won't partner with anyone because we want to partner with ones where people actually want to go to work. And so that's the reason one of the things that we offer, and this is not a sales pitch, but what I call it is a reliability part of our business is we offer a 1-year guarantee with every placement we do, because we know if we're partnering with the right candidate or with the right company, that person will stay. And we have a 97.3 success rate with that. So trying to wrap all this together because it's just very important to understand the brand, very important to understand retention before you even decide how am I, going to recruit. And last, I know we're running out of time here, is the technology end. If you're not using technology to help with your recruiting, you're really missing out because there are such large advances in technology, recruiting technology for clinical and non-clinical talent that you really need to utilize and integrate into your recruiting strategy. One of the things that we do, we have our own technology called Talentlytical. And as I also said at the beginning, you just can't rely on job boards anymore. You just can't rely on referrals. You have to look to the future, and technology is a big piece of that. So we have our own proprietary technology, that really helps us find more qualified candidates than going the traditional route. And so in theory, when you look at technology, one of the major things that it should do, especially from an AI standpoint, it should really bridge the gap between your needs for staffing and reducing the cost of hire. Cost of hire is so expensive in healthcare, regardless of the position. So if you hire someone, there is a large cost attributed to that. And then you've got the cost of turnover or the cost of attrition. And so if that person is only staying 6 months to a year, you have lost a significant amount of dollars. And so what we utilize technology for is not only finding more qualified candidates, but also utilizing that technology so these candidates are the type of match, employer match, that will help you retain those types of individuals. Today's telehealth, I won't go through this, but as you can see just from the slide, significant growth, and these numbers were just released by the CDC in October, and they'll continue to increase versus the numbers that I showed you previously. All right, we'll stop for questions. I know we only have a few minutes, but there is an appendix to this. I'm not going to go through it, but it's pretty interesting. I did a webinar 2 years ago, right in the middle of COVID. And we were talking about trends that were happening. And it's really interesting, and you can do this on your own time, to look at that presentation and the numbers in that presentation, and then now look at the numbers 2 years later. And I think it'll validate what I've been saying about the growth of telehealth and its impact on staffing and really on the healthcare industry as a whole. So when you have time, you can proceed with that. But I appreciate listening. Are there any questions? We'll be sending out a survey in the next couple of days about the call, about any other questions that you weren't maybe able to ask during this presentation.
Thanks so much, Mike. That was really awesome. There actually are not any questions in the chat right now. A couple people asked if the slide deck would be available, and we'll make sure to share that with everyone so you could take a look back at it. If there are any last minute questions, feel free to pop them into the chat now with a minute left. Otherwise,
Nancy, can I ask Mike a question?
yes, of course.
Mike, are you seeing healthcare organizations and hospitals? Is there a trend in looking at staffing as an outsourced solution, working, say, with an outside agency? I know a lot of healthcare organizations have multiple agencies, but are hospitals looking at ways of maybe outsourcing or offlining the recruiting process to third parties?
Yeah, no, we're seeing the increase, recruitment process outsourcing, RPO. Yeah, we do several of those, and we have seen an increase in that. There are several hospital chains that have created their own staffing company. One here in Florida, Baycare, just announced a few months back that they were starting their own staffing company. So they are looking for creative ways because they understand it's just the pure process. They may not have the internal resources to do it. So some may partially in some areas outsource, some may keep some of that inside. But yes, there definitely is a increase in the number of just in the healthcare industry looking to do a RPO type business.
Nancy, I think we're pretty much at the top of the hour, so I have nothing further.
Yep, we are just about at 3 o'clock. Thank you everyone for joining us today. Again, we will be following up with the recording link, notes from the session, as well as the slide deck, and I'll be sure to include both Mike and Peter's contact information. If you do think of any other questions in the meantime, please feel free to reach out to me with them, and we will make sure that those get addressed. Otherwise, this is the last Learning Collaborative of 2022. I will be following up with everyone with our schedule for next year. And I hope that everybody has a nice Thanksgiving and rest of the holiday season. Thank you again, everyone, for joining. Thank you, Mike and Peter, for the presentation, and have a wonderful rest of your day.
Thanks, Nancy. Take care, everyone.